Hi everyone, I'm back again. The topic is still acute cancer pain syndrome and treatment, but today is going to be part 2. Before you can enjoy this part 2, kindly listen to part 1. Check my channel for that. Okay, thank you. Let's go. Tramadol and tapentadol are centrally acting and they could block monoamines reuptake. The commonly used opioids for cancer are long-acting pure mu receptor agonists for chronic pain. An example will include fentanyl, that is transdermal patch. Example will be Duragesic at 12 to 25 micrograms per hour for 72 hours. The half-life of Duragesic is 17 hours. Analgesic effect will last 48 to 72 hours. The onset of Duragesic is between 12 and 24 hours. Another example is Hydromorphone. Hydromorph Contin at rate of 3 mg per hour every 2 hours, or Exalgo at 8 mg per hour every 24 hours. But watch out for renal and hepatic failure. Exalgo has abuse-deterrent properties, and that is pretty good to prevent abuse, addiction, and subsequent death. Morphine could come in form of Arymo extended release at 15 mg per hour every 8 to 12 hours. It can be Kadian at 30 mg per hour once daily, or 15 mg per hour twice daily. If you want to use MS Contin, it's going to be at a rate of 15 mg per hour every 12 hours. Here, you have to watch out for renal failure because of the possible hyperalgesia secondary to metabolites accumulation that could also lead to neurotoxicity. Arymo extended release has abuse-deterrent properties. That is pretty good to prevent addiction, abuse, and the lethality that may follow. Hydrocodone will come in form of a singular extended release at 20 mg per hour every 24 hours. Also, Zohydro extended release at 10 mg per hour every 12 hours. Enzyme inhibitors and inducers can alter the concentration because metabolism is by the liver cytochrome enzymes. So, if there are enzyme inhibitors, the concentration of hydrocodone will be high in the system. But if there are enzyme inducers, the hydrocodone will be quickly metabolized and will have low or decreased effect. So decreased analgesic effect in the face of enzyme inducer, but toxicity in the face of enzyme inhibitors. Hysingla extended release, also Hydro extended release have abuse-deterrent properties. That is very helpful to prevent against addiction, abuse, and subsequent lethality. Oxycodone could come in form of Oxycontin 10 mg per hour every 12 hours, Zohydro 10 mg per hour every 12 hours, or Zitamsa extended release 9 mg per hour every 12 hours. They all have abuse-deterrent properties, and that is going to prevent lethal effects of this medication. Oxymorphone could come in form of 5 mg per hour every 12 hours, should be taken on empty stomach, and we use only generic extended release form. The immediate release form could be in form of Hydromorphone, example Duragesic, at 2 to 4 mg per hour every 3 to 4 hours, or Meperidine at 2.5 mg to 10 mg per hour every 4 to 8 hours. But remember the half-life because it could be as high as 7 days. Overdose is very possible because if you don't take into account the long half-life, you could even be double dosing. Morphine immediate release could be at the range of 15 mg to 30 mg per hour every 4 hours. Oxycodone, that is oxy immediate release, or Oxycodone could come at the rate of 5 to 15 mg per hour every 4 to 6 hours. Could be combined with acetaminophen, aspirin, or ibuprofen. Oxymorphone, that is Zupana, could be in form of 5 to 10 mg per hour every 4 to 6 hours, and it is advisable to be taken on empty stomach. Parenteral preparations could be fentanyl sublinase, 25 micrograms to 50 micrograms intravenously or subcutaneously every 1 to 2 hours, or infusion intravenously or subcutaneously. Hydromorphone, that is dilaudid, at rate of 0.3 to 1 milligram intravenously or subcutaneously every 2 to 4 hours, or intravenous or subcutaneous infusion. Methadone at 1.25 to 5 milligram intravenously or subcutaneously every 4 to 8 hours, or morphine Hydromorph at 2 to 5 milligrams intravenously or subcutaneously every 2 to 4 hours. Oxymorphone at 0.5 milligram intravenously or 0.5 to 1.5 milligrams subcutaneously every 4 to 6 hours. These analgesics could be combined, and that's why I put it simply as combinations. In case of Percocet, there's a combination of Oxycodone and acetaminophen. Channel 1, 2, 3, 4, we have codeine variable concentration with fixed concentration of acetaminophen and caffeine. For example, Tylenol 1 we have 8 mg codeine, Tylenol 2 15 mg, and so on. Tramadol we have tramadol with acetaminophen with fixed tramadol concentration at 37.5 mg and acetaminophen at 325 mg. Apple test we have apple tramadol at 37.5 mg and acetaminophen at 325 mg. Meperidine is less useful, and someone will ask me why that. The metabolite that is known meperidine is very toxic. There's likelihood of tremulousness, that is quivering, and the individual could go into delirium or even come down with seizures. Tramadol or tapentadol are centrally acting. It binds mu receptor and monoamine. In other words, serotonin and norepinephrine reuptake are blocked. Buprenorphine is good for the treatment of opioid addiction and also for treatment of chronic pain. Butrans is an example. It's a patch with either 5, 10, or 20 micrograms per hour. Buprenorphine buccal is also available, given daily or twice daily. Rectal formulations are available. Morphine, for example, could come in 5, 10, 20, or 30 milligram suppositories, while Hydromorphone could come in 3 milligrams suppository and Oxymorphone at 5 milligrams suppository. PCA is patient control analgesia. You can check my video on this. I made a separate video on PCA. Please, I'm not going to waste your time going over that right now. Just kindly go through my channel and you're going to get that and listen to it. If we have given these good medications and we are not having good responses. In other words, good medication, highly potent ones, within the acceptable dosage, yet poor response. Then something is going on. And the next thing is we should ask ourselves, is this as a result of cancer progression, or we're dealing with new fracture somewhere that we've not even diagnosed, or are we even dealing with neuropathy and we're giving only opioids? We're not likely going to get out of it. So we're going to add adjuvants like tricyclic antidepressant, amitriptyline, or nortriptyline, and I will choose nortriptyline in elderly people. And we can go for anti-epileptic drugs. Then we can go for antidepressants like the venlafaxine or duloxetine or the. You can even use calcium channel blockers and gabapentin or pregabalin. Is this fibromyalgia? Then why are we giving opioids? It's not going to help. We're going to cut off opioids completely from fibromyalgia and try tricyclic antidepressant. It's likely going to help. And that is not helping, you can give anti-epileptic drugs as well. Is this psychological? Then why giving any medication? Other adjuvants or opioids would not work with the psychological. Is this individual seeking narcotics? No matter the dosage, no matter the potency, the individual will still come back asking for it. Okay? Is this even non-cancer pain? Oh, wow. Maybe there's opioid diversion here. You are giving this patient, and when you turn your back, he or she stocks it somewhere in the pocket, somewhere that you can't even imagine, and they go out to sell it. Is that shocking? It's possible. Or we are dealing with someone with dementia who could not even tell exactly what the situation is and whether he or she has taken medication or not, or whether he or she is even feeling pain or not. That might be the problem. Or we're battling with delirium here. Okay? The acute confusional state. Someone is confused. Okay? So we need to go over all these possibilities. If we think we have given our Hydromorph, we've given MS Contin, we've given fentanyl, and the patient is still in pain. Unfortunately, we don't have the device to detect pain level right now. And it has become the fifth vital signs because all the time we ask patients whether they have pain anywhere in the body. Still on poor response. Is this a psychiatric condition? If not, we'll be dealing with toxicity or side effects of the medication in someone who doesn't even really need it. Okay? Or has this patient developed tolerance? At that stage, we will have to increase the dosage before we could get the same effect. Or toxicity. That is an ironic situation, right? You can have hyperalgesia even from giving morphine, nausea, delirium, or sedation. Patch adhesive failure. Maybe it has not been perfectly fixed to the cutaneous or the skin, or impaired peroral absorption. Are there any other problem along the gastrointestinal tract? Is there ascites or renal failure or anything? And the absorption is impaired. So you are loading with the peroral, but the absorption is impaired, so it's not going to get to the circulatory system and the effect will not materialize. Or you are giving intramuscular medication in somebody who has edema. it's just going to sit down there and bind to the tissue, or you are not aware about the lipophilic status of the medication you are giving. So if it is highly lipophilic and you are giving intramuscularly, you're not going to get any results, or you get very low, or you get any. So it depends on the absorption that is going to lead to effect. So the pharmacokinetics and pharmacodynamics of what we are giving will be taken into account here. If for response, we should check high metabolism. Example is hepatic enzyme inducers. Maybe you are giving these medications and then you are combining it with strong enzyme inducer like rifampicin. Now, somebody is on TB management or any antibiotic reason that rifampicin has been prescribed, shooting the hepatic cytochrome P450 enzyme out, and you are giving medication that is going to be metabolized by the same route, then you are not going to get effect. Delivery devices should be checked. PCA, the pump, subcute line, the IV lines, check the needles, make sure everything is in order so that we don't unnecessarily increase the dosage. Just rule out all possible causes that may not be related to the potency of the medication itself. Okay, the medication appears not to be working, or you've given many medications and they are not working, apparently. Let's don't know the cause. So go over my presentation again. Check and check and check and check until you get to the root of the failure. And once you're able to get that, correct the failure, please. Go to the root and correct it. If this is a result of psychological problem, then why not giving psychological therapy? Okay. If you think surgical intervention will help, why not inviting the surgeon or send a referral? Okay. You can add non-steroidal anti-inflammatory drugs, and you can add adjuvant analgesic like tricyclic antidepressant, like anti-epileptic drugs, calcium channel blockers, venlafaxine, duloxetine. Now the list goes on. Treat side effects. Why that? Okay, it might be because this individual is having side effects now, and that is discouraging. Because of the side effects, he or she is no longer interested in taking the medication and might not be telling you the truth, but you can also, from history, be able to get the fact that this person has started developing side effects, and that's why he or she is not taking the medication. Okay, you might change the route or the form of the medication. For example, if it's fentanyl patch, you might decide to use sublingual tablets, buccal film, nasal spray, and so on. You might choose more potent ones, like if the individual had been on Hydrocodone and you are not winning, then why not try Hydromorphone or fentanyl or Morphine? You can also add spinal or intrathecal analgesia. And to sum it up, once you are not just getting what you're supposed to get, then you try something else. I've come to the end, but before signing out, I want to state here that I am actually feeling for everyone who has been diagnosed with cancer, because the pain could be so excruciating, could be so unbearable. So my thought and prayer with you. Thank you for listening to my presentation. Kindly subscribe to my channel so that once these presentations are published, you can have a copy. Thank you.